Okay, picture this. You need to get your head around a complex medical topic fast. Maybe it's for an exam, maybe a clinical meeting, or, maybe you're just curious about pregnancy and its complications.
Yeah, you've got these revision notes, maybe a whole stack of them,
Yeah,
and you need the key takeaways, like, now.
that is exactly what we're doing today. Welcome to the deep dive. We are diving into preeclampsia.
And we're using a specific set of revision notes as our guide for this.
Yeah, these notes look really solid, packed with the essentials. So our mission today is to unpack them with you.
Pull out those high-yield facts, the stuff you really need to know, and help it make sense, help it stick.
Exactly. Think of this as your focused guide, making revision easier or just making sure you're properly informed about, well, a really significant condition in pregnancy.
Absolutely. We'll cover everything these notes touch on: definition, causes, risks, management, the whole picture. We want you walking away feeling, pretty clear on the core concepts.
All right, let's jump in then. Preeclampsia. What exactly is it? Where do the notes start us off?
Okay, so fundamentally, it's a condition that crops up during pregnancy. And the really key thing, it typically appears after 20 weeks gestation.
Right, that 20-week mark is crucial. And the notes, they give a pretty specific definition, don't they? It's more than just high blood pressure.
It is, yeah. The formal definition is about new-onset hypertension. So blood pressure hitting 140 over 90 milliliters or higher, consistently appearing after that 20-week point. But, and this is critical, it's the high BP plus either significant protein in the urine, that's proteinuria, or evidence of other organ involvement.
Other organ involvement. Okay, that sounds cool. Well, serious. What sort of things are we talking about there according to these notes?
They list quite a few possibilities. Kidney issues, so renal insufficiency, problems with the liver, neurological symptoms like really bad headaches or visual changes, seeing spots, that kind of thing.
Okay.
Also, blood abnormalities, hematological issues, and dysfunction of the uteroplacental unit itself, which affects blood flow to the baby.
So pulling those characteristics together from the notes, you've got the mother's high blood pressure, protein in the urine, maybe swelling or edema, and potentially effects on the baby, like growth restriction or even premature birth.
Precisely. And the notes draw a clear line for severe preeclampsia. That's defined by even higher BP readings, diastolic hitting 110 or more, or systolic 160 or more.
Wow.
And that's combined with significant symptoms or actual signs of organ impairment showing up on tests.
And the notes mention something quite stark about the baby in severe cases.
Yes, they do. They highlight the risk of neurological damage to the fetus or the newborn because of hypoxia, basically a lack of oxygen. And that really underlines the urgency mentioned throughout these notes. Spotting the signs quickly and getting that prompt referral to specialist care is just vital.
So for you listening, if you're revising this, the absolute core takeaway, usually after 20 weeks, it's not just the high BP. It's BP, typically 480 or more, plus protein in the urine or those other organ issues.
And severe means much higher BP and clear signs of organ problems. The notes really stress acting fast.
Okay, so we have a clear definition of what it is, but what's really interesting and maybe a bit surprising is the notes state the exact cause isn't fully understood.
Yeah, that's a big point.
So if the full picture is still a bit of a mystery, what do the notes suggest are the likely culprits? Why does this happen?
Well, the section on etiology, the cause, it points to several key factors, even if the initial spark isn't totally clear.
Okay.
They talk about suboptimal uteroplacental perfusion. Basically, the blood flow between the uterus and placenta isn't working as well as it should.
Right.
There's also a significant maternal inflammatory response going on.
Yeah.
And dysfunction of the vascular endothelium, that's an inner lining of the blood vessels.
And what does that chain reaction lead to? What are the results listed?
According to the notes, it results in things like vascular hyperpermeability, leaky blood vessels, a tendency towards increased blood clotting called thrombophilia, and of course, the hypertension itself. The notes even suggest the high BP might initially be the body trying to compensate for reduced blood flow to the uterus.
And these notes really seem to place the placenta center stage in all this.
Oh, absolutely pivotal. They also briefly mention genetic factors playing a role and pre-existing conditions like chronic high blood pressure or kidney disease as contributing to the underlying risk.
Okay, so the why involves issues with placental blood flow, inflammation, problems with blood vessel linings, maybe some genetic predisposition, and existing health issues mixed in. How does that actually unfold in the body? What's the pathophysiology described?
The notes describe it starting early in pregnancy with abnormal development of those crucial placental blood vessels. instead of forming wide open channels ready for increased blood flow. That development is impaired. They don't remodel properly.
And the consequence for the baby then is?
Reduced blood flow and oxygen supply. This initial placental problem then seems to set off this sort of cascade, a widespread reaction in the mother's system.
Right.
The note suggests this leads to that endothelial dysfunction we talked about, the blood vessel lining issue, widespread inflammation, and systemic vasoconstriction, where blood vessels tighten up all over the body, driving that blood pressure up.
So you can almost see it starting local at the placenta and then sending out signals that affect the whole maternal system. It's quite a complex interaction.
It really is. And the notes acknowledge that the precise mechanisms are still being figured out, which is, a good reminder that even with conditions we know a lot about, there are still layers we're uncovering.
So for you listening, maybe think of it like a chain reaction. Starts with placental problems, leads to systemic vascular issues, and high BP.
Yeah, that's a good way to frame it.
Which brings us logically to the next really crucial question these notes cover. Who is most likely to get preeclampsia? What are the risk factors?
Yes, susceptibility. Do the notes list the sort of well-known ones?
They start with the common high-impact factors. A history of preeclampsia in a previous pregnancy, that's a big one.
Definitely. Other major ones listed are pre-existing conditions, chronic high blood pressure, chronic kidney disease, also obesity, carrying multiple twins, triplets,
right,
having over 35, and having existing conditions like diabetes or autoimmune disorders.
And the notes actually add a few more to that list as well.
They do. They broaden it out. Things like it being your very first pregnancy or having a really long gap, like over 10 years since your last one.
Okay.
Increasing age in general, specifically mentioning age 40 or older as a moderate risk. A high BMI, they specify over 35 at the first antenatal visit. A family history of preeclampsia, like in your mother or sister, and then those comorbidities again. Previous preeclampsia, chronic hypertension, kidney disease, diabetes, autoimmune diseases like lupus.
And these notes usefully group these risks into high risk and moderate risk. That seems really important for deciding on prevention strategies.
Absolutely crucial. The high risk factors they list are having had a hypertensive disorder in a previous pregnancy, chronic kidney disease, autoimmune disorders. They mention lupus and antiphospholipid syndrome, specifically type 1 or type 2 diabetes, and chronic hypertension.
Okay, those are the big ones. And the moderate risks.
Those are things like first pregnancy, being 40 or older, that pregnancy interval of more than 10 years, BMI of 35 or more at booking, family history of preeclampsia, and carrying multiples.
And this grouping directly leads to the main prevention recommendation in the notes, aspirin.
Yes, low-dose aspirin. It's recommended for women who have one or more of those high-risk factors, or two or more of the moderate risk factors.
Right, and here's a detail from the notes that's quite specific, maybe easy to remember because it's a bit unusual.
Oh, yeah.
It mentions that changing partners after having preeclampsia in a first pregnancy seems to reduce the risk of it happening again before 37 weeks in the next pregnancy.
Huh. That is a very specific point noted in the source material. Interesting.
So for your revision, maybe make a mental checklist of these risk factors. You could group them things you can't change, like your history, age, family history, and things related to general health. Spotting these helps identify who needs that preventive aspirin.
Good strategy.
Okay, so we know what it is, roughly why it might happen, and who's at higher risk. What does it actually look like? What signs and symptoms should someone be aware of, according to these notes?
Well, we circle back to that core definition for the most common signs, right? The clinical features section lists them clearly. High blood pressure, significant protein in the urine, proteinuria, and often edema swelling, especially noticeable in the hands and face.
But the notes stress it can go beyond just those three, linking back to that organ involvement we mentioned earlier.
Exactly. They list other symptoms that suggest those other organs are feeling the strain. Things like persistent headaches, the kind that don't ease up with simple painkillers. Visual disturbances, blurred vision, flashing lights, seeing spots. Pain in the upper abdomen, often described as epigastric or under the ribs on the right side. And sometimes a noticeable change or decrease in the baby's movements.
And the features of severe preeclampsia are laid out as needing really urgent attention.
Yes, definitely more pronounced, more concerning. These include that much higher blood pressure, often over 160 systolic or 110 diastolic, very significant proteinuria.
Okay.
Severe persistent headaches, worsening visual problems, tenderness or severe pain in that upper abdomen liver area, hyperreflexia, really brisk reflexes when tested,
Awkward.
and worrying blood test results like a low platelet count under 100,000 or significantly abnormal liver enzyme levels.
The notes also specifically mention HELLP syndrome here as a type of severe preeclampsia.
Yes, and HELP is a super important one to remember, especially for revision. It's a great mnemonic. H for hemolysis, that's breakdown of red blood cells, EL for elevated liver enzymes, and LP for low platelets, HELLP.
Okay, HELP, hemolysis, elevated liver, low platelets. Got it.
Other severe features mentioned can include swelling at the back of the eye, papilledema, signs the baby is in distress, or significant fetal growth restriction.
Moving to epidemiology, how common is this? The notes give some stats.
They do. They state it affects somewhere between 2 and 8% of pregnancies in the UK, but the actual rate depends on things like age, ethnicity, and those risk factors we discussed.
And there's a pretty sobering statistic included about its impact.
Yeah, it's cited as the second leading cause of direct maternal deaths.
Wow. That really underlines why understanding and managing it well is so critical, even though, thankfully, overall maternal mortality is low in places like the UK.
Exactly. The specific rates for the severe forms are lower, around 5 cases per 1,000 pregnancies for severe preeclampsia, and about 5 per 10,000 for eclampsia, which is when seizures occur.
And the notes break down the timing of those seizures, too, which is interesting.
It is. Apparently, 44% happen after the baby is born, postnatally, 38% happen before labor starts, antepartum, and 18% occur during labor, intrapartum.
Huh. More common after birth than I might have guessed.
Yeah, it's significant. The notes also mention preeclampsia's contribution to premature births. About half of severe cases lead to delivery before 36 weeks.
And while it's serious, the overall diagnosis rate for preeclampsia itself is noted as relatively low, around 0.5%.
That's what these notes state, yes. And eclampsia occurs in about 10% of those diagnosed with preeclampsia. The maternal mortality from eclampsia is thankfully very low, 0.38 per 100,000 pregnancies, reflecting good care.
The notes also tuck in some practical tips on measuring blood pressure accurately. Seems basic, but important.
Absolutely fundamental.
Yeah.
Sitting or semi-reclining, arms supported at heart level using the disappearance of sound, Korotkov phase 5 for the diastolic reading usually, and avoiding using an arm that has an IV drip in it. Simple things, but they ensure accuracy.
Okay, so for your revision on features in epidemiology, think about the spectrum. The basic signs, the organ involvement signs, and then those specific severe features, including HELLP.
Right. The stats give context to the seriousness, but the low mortality in well-resourced settings is also key. And don't forget those BP measurement basics.
All right, so if someone shows these signs or has the risk factors, how do clinicians actually check for preeclampsia? And then how is it managed? What do these notes say about investigations?
Starting with the standard checks, the basics.
Yeah.
Okay, the notes list the key things. Regular blood pressure monitoring that's constant, urine analysis, specifically looking for that protein, and blood tests are crucial.
What are they looking for in the blood tests?
Checking organ function mainly. So liver enzymes, kidney function markers like urea and creatinine, clotting factors, and the platelet count. Ultrasound scans are also vital for monitoring the baby's growth and well-being, all done as part of regular antenatal monitoring.
And these notes seem very clear on the triggers for sending someone to the hospital.
Yeah.
The referral criteria. This feels like really important high-yield info.
It absolutely is. You need to know this. Hospital admission referral to secondary care is recommended if a woman has that raised BP, 140/90 or more, and proteinuria of +1 or higher on a dipstick test.
Okay.
Or if her systolic BP hits 160 or more, or her diastolic hits 100 or more, regardless of whether there's protein in the urine yet. And crucially, the notes say any clinical symptoms or signs suggesting preeclampsia, even without those exact BP numbers, should also trigger a referral.
Right, so symptoms alone can be enough. The notes also mentioned a relatively newer test, placental growth factor, PLGF.
Yes, PLGF testing. This is specifically recommended by NICE-E, the UK guidelines body. It's particularly useful for helping diagnose or more often rule out suspected preeclampsia when it might be starting early, between 20 weeks and about 37 weeks.
How does it help?
The notes say it helps clarify the picture, rule out the condition faster if it's not there, which avoids unnecessary interventions and helps plan care better if it is present. It's also mentioned as useful for women who already have high blood pressure, where spotting superimposed preeclampsia can be tricky.
Okay, makes sense. So once it is diagnosed, how do the notes describe the management approach? What are the goals?
The main goals outlined are closely monitoring and controlling the mother's blood pressure, preventing complications from kicking off, and ensuring the well-being of both mom and baby as much as possible.
And the actual treatments listed, what options are there?
Options include really close monitoring of both mother and baby. Sometimes bed rest is mentioned, though practice varies on this. Definitely medication to lower the blood pressure. Giving antenatal corticosteroids, those steroid injections to help the baby's lungs mature if an early delivery looks likely. And then, in severe situations, planning for or carrying out an early delivery.
Because, and the notes state this very clearly.
Yes, the only definitive cure for preeclampsia is delivery of the placenta. That's the fundamental point.
Everything else is management until that point.
Exactly. All the monitoring, the meds, it's about managing the condition, keeping the mother stable, and allowing the baby time to mature until delivery becomes the safest course. Hospital management is described as needing a whole team, multidisciplinary, and conservative management, basically watchful waiting with close monitoring, might be an option up to 34 weeks if and only if the mother is stable and doesn't have severe features like HALP or clotting problems.
The notes also give a nice staged approach to managing the blood pressure itself based on how high it is.
Yeah, they break it down quite clearly.
Okay.
Mild preeclampsia, where the BP is 140/149 over 90/99, focuses mainly on monitoring BP and basic bloods.
Makes sense.
Moderate, BP 150/159 over 100/109. Keep monitoring, but now you start antihypertensive medication. Labetalol and nifedipine are the examples given.
Okay, starting meds there.
And severe.
Severe, BP 160/110 or higher. This needs intensive BP monitoring, probably in a high dependency setting, and immediate start of antihypertensives, again mentioning labetalol or nifedipine as first-line options.
And what about preventing those really dangerous seizures, eclampsia?
No.
Magnesium sulfate. That's the key drug highlighted for both preventing seizures prophylaxis and treating them if they occur in preeclampsia or eclampsia. Fluid restriction is also mentioned as something to consider carefully to avoid overloading the system.
Okay. And what about the actual delivery and what happens afterwards, postpartum?
Delivery timing is tailored to the individual case, how severe it is, how the mother and baby are doing. But like we said, it's the cure. Antihypertensive meds are usually continued after birth.
Right.
Magnesium sulfate might also be continued for, say, 24 hours postpartum to prevent those postnatal seizures, which we saw are quite common. Monitoring of mom's BP and the baby's condition continues right up to delivery. The how of delivery induction C-section depends on the situation.
And after birth.
Postpartum care means keeping a close eye on BP, gradually reducing meds as it comes down, and making sure there's good follow-up, especially if the woman has underlying conditions like chronic hypertension.
And if eclampsia, the seizures actually happens, what's the management then?
That's a full-on medical emergency. It's about immediate resuscitation, ABC approach, using magnesium sulfate immediately to treat and prevent more seizures, getting that severe hypertension under control quickly, and managing fluids very carefully. And again, delivery is the definitive treatment once the mother is stabilized.
Okay, so for revision on investigations and management, remember the core tests, BP, urine, bloods, ultrasound. Know those crucial referral criteria cold?
Definitely.
Understand PLGF is a newer tool, especially for ruling out preterm disease. For management, anchor on delivery is the cure. Then add the layers before that, monitoring, the staged BP control, labetalol, nifedipine examples, and seizure prevention with magnesium sulfate.
That covers the essentials from the notes, yeah.
Finally, let's look at the longer view. What's the prognosis, the outlook, and what potential complications do these notes highlight?
Okay, prognosis first. What do the notes say generally?
They say it varies quite a bit, depending on how severe the preeclampsia was, how early in the pregnancy it started, and whether complications developed. But with good prompt management, the notes suggest women usually recover well physically afterwards.
But it definitely increases risks during that specific pregnancy and birth.
Oh, absolutely.
Yeah.
It significantly bumps up the risk of things like premature birth, the baby having a low birth weight, and potential damage to the mother's own organs, kidneys, liver, brain, during the acute phase. The notes specifically mention the maternal mortality rate directly linked to eclampsia is about 1.8%.
And what about the risk of it happening again in future pregnancies?
The recurrence risk is mentioned, yeah. It's quite variable, quoted as anywhere from 15% to 50%, depending on various factors like severity and timing in the first instance.
And there's that really important point about long-term health.
Yes, this is a critical takeaway from these notes for anyone listening. Having a history of preeclampsia significantly increases a woman's risk of developing chronic high blood pressure and cardiovascular disease later in life. It's not just about the pregnancy, it casts a long shadow.
That's a really key message. Now, moving on to the specific complications, what are the major serious issues the notes explicitly warn about?
The big ones listed are eclampsia itself, the seizures,
Yeah.
HELLP syndrome, which we broke down, placental abruption, where the placenta detaches too early, premature birth, fetal growth restriction, and those long-term cardiovascular risks we just mentioned.
And the notes link eclampsia specifically with potential problems across multiple body systems.
They do. And they mention a specific, though thankfully uncommon, risk of cerebrovascular hemorrhage, bleeding in the brain happening in maybe 1–2% of severe cases.
So serious potential outcomes. The notes also briefly loop back to prevention here, summarizing the strategies again.
Right, just reiterating the importance of identifying those risk factors and symptoms early. Using low-dose aspirin for women identified as high or moderate risk, noting it offers moderate benefit. And mentioning calcium supplements, especially for women with low dietary intake, might have a role.
Okay, so thinking about prognosis and complications for revision. Prognosis, generally good with management, but know the immediate risks it increases. Prematurity, low birth weight, organ issues, and that crucial future cardiovascular risk.
And the complications are those specific dangerous events: eclampsia, HELLP, abruption, the impact on the baby, and that long-term heart health link.
Pulling all this together from these specific revision notes, it paints a picture of preeclampsia as, well, a condition we know a lot about in terms of risks, diagnosis, management pathways.
Yeah, the criteria are quite defined, the management steps are established, the potential complications are known.
And yet what really lingers is that statement right near the beginning in the notes. The fundamental exact cause, still not fully pinned down.
It's fascinating, isn't it? It highlights how much progress medicine has made in managing conditions effectively, even while still investigating the deepest underlying mechanisms. It's that mix of, solid clinical knowledge and the ongoing scientific quest.
Exactly. And using focused sources like these revision notes helps you nail down that essential clinical information you need, while also giving you that wider perspective on the condition's complexity.
Well, hopefully we've taken this set of revision notes and turned them into a pretty clear, high-yield deep dive into preeclampsia for you. Our aim was really just to pull out the most important bits and make them memorable.
Yeah, we hope this deep dive has distilled the key knowledge from the source material in a way that really clicks, whether it's for your revision or just for staying informed on an important topic.
And hey, if you are currently studying for exams like the MSRA or other medical assessments and you found this kind of breakdown useful, remember you can find loads more comprehensive resources designed to help you succeed over at passthemsra.com.
Plus, for free practice questions, some great study tools to help along the way, make sure you check out freemsra.com.
Thanks so much for joining us on this deep dive.